Welcome to the fifth in a series of anatomy for the medical professional. This is a topic about spinals and epidurals. Just a few things you need to know, not everything, but some of the real important information about the anatomy, the uses of spinals and epidurals, the benefits, and a few of the complications that can happen. I am Dr. Gustafson. I'm recording these lectures with dogs chewing dog bones. I'm trying to keep them quiet. But the first thing we want to talk about is how your spine gets formed, some of the defects in the spine, and the neuraxial blocks. Neuraxial means, if you're in anesthesia terms, that you're doing a blockade of the nerves closest to the spinal cord. So the spinal cord would include blocks that are called spinals and epidurals. First case scenario, your sister has decided that she's going to stop birth control pills. She's wanting to get pregnant in the next few months. Why is it a good idea to start her prenatal vitamins even before she gets pregnant? The neural tube is the tube that surrounds the spinal cord, and that starts really early. That usually starts before people even know that they're pregnant. This shows a depiction of the spine closing at 21 days after conception. And if this doesn't close completely, then you get what they call a spina bifida defect. Prenatal vitamins contain folic acid, and that helps to prevent neural tube defects. So spina bifida is different stages. A spina bifida occulta is, you might just see a little tuft of hair. That doesn't cause any neurologic defects. And then there's a meningomyelocele, where just the meninges of the spinal, the dura, the arachnoid, the pia mater, they can kind of bulge out. But the worst is the spina bifida, where some of the actual nerve contents are bulging out, and this will cause the paralysis. So in screening, they usually do an alpha-fetoprotein level in mothers at 15 to 18 weeks during pregnancy. And also later on can start seeing the spine to actually form in utero under really good ultrasounds. And some of the risk factors, besides poor nutrition, not having enough folic acid, are things like advancing age of the mother, family history, or some of the teratogens, some of the medications that have been used in the past, like thalidomide and valproic acid. Those were used for prevention of nausea and vomiting early in pregnancy. Folic acid can also be found in some of these other, of course, nutritional supplements. So in addition to the prenatal vitamins, it's also having a very good diet. So now your sister is 9 months pregnant. She's got twins, and she's scheduled for a cesarean section, and they're going to do it under spinal anesthesia. She wants to know if the spinal needle will hit the spinal cord and make her paralyzed. She must have heard stories. So now, what are you going to tell her to calm her down? Are you just going to say, just don't worry about it? Or A, or answer B, the needle is placed below the end of the spinal cord? Or C, you're going to try to change the topic of conversation? And the correct answer is B. The needle is placed below the end of the spinal cord. Let me go through the spinal cord segments, and we'll talk about how the spinal cord develops with age. Just a reminder, these are the different segments of the spinal cord. We're going to be talking about them in relation to where a spinal and an epidural are actually placed. So this is a sagittal view of the spine. Cervical, thoracic, the lumbar. In spinal blocks, the blocks are placed in this lumbar segment. Epidurals can be placed actually up higher, but we'll go through that. In the adult, the spinal cord turns into what they call a cauda equina, or the horse's tail. So the bulk of the spinal cord ends right about the L1, the first lumbar vertebra. As a fetus, interesting, at 3 months gestation, the spinal cord is all the way to the bottom of the coccyx. But then the spinal cord itself stops growing and it stretches upwards. So at birth, the spinal cord is at the L3-4. So this area below L3-4 becomes the cauda equina. And then the adult, as your spine grows, as you grow in height, your spine doesn't grow. I mean, your spinal cord doesn't grow, doesn't get any longer. And so it ends about L1. And then from L1 down to your coccyx becomes the cauda equina. And that's floating in that cerebral spinal fluid. And so when the spinal needle comes in, the needle will push away the cauda equina, and there's no risk for paralysis. What are the reasons you would want to access the cerebral spinal fluid in the first place? Would it be for checking for meningitis, for infection, a spinal block for anesthesia, giving no need for general anesthesia? Would you want it for long-acting pain control, or all of the above? And if you're guessing all of the above, you are right. For the diagnostic tab for checking if you have meningitis, the spinal fluid shouldn't be completely clear, colorless. If you do it at the beginning, if you check the fluid at the beginning, there might be a few red blood cells just from the trauma of placing the spinal needle. And then what they'll do is have subsequent vials, and they'll label them 1, 2, 3, 4. So you'll collect vials 1, 2, 3, and 4, and they'll check them to see if the numbers of red blood cells decrease. And that tells you whether it was a traumatic stick or whether there's actual intracranial bleeding. And then there should not be any white blood cells. If there are any, then that suggests that there's an infection. One of the reasons I got really involved with spinal blocks is because they're very safe and they take away the need for supplemental oxygen. For instance, if you're trying to conserve your oxygen, they take away the need for a ventilator, and they make it a very safe option for low resource settings. And this is an image of South Sudan. Initially, I started teaching spinal blocks in Ghana back in the late 2010. This was a clinic that was doing up to 12 hernia surgeries a day. They didn't have general anesthetic capabilities. Oxygen was very limited. And they would be doing all of these hernia repairs under just a local field block. And they would be using extensive doses of lidocaine, which can be actually toxic if given in massive doses. And the patients were not able to be still. And some of these surgeries were challenging. And then you'd have a patient that was moving all over the place. With doing spinals, they were able to convert this into very efficient blocks where they could put the spinal block in. The patient would be completely comfortable during the surgery, and it was a short-acting medication that they used, and they would be able to go directly to the ward after the surgery was finished. This was carried on to Uganda over a subsequent 10-year period of time, teaching how to do spinal blocks, especially for women that were having cesarean sections. Again, oxygen is limited, and allows for newborn and maternal safety. If a mother has a spinal block, the baby gets very little, if any, of the local anesthetic, the lidocaine or the marcaine that's placed in there, and the surgeon can take their time delivering the baby. And so when the baby is born, they're not anesthetized. This is further on. This is recent in South Sudan. This is an example of a patient who had a snake bite injury. It took her 2 days to reach the facility, and by then her leg was severely swollen, and she was starting to lose her pulses in her feet. Distal means distant from the heart. So she was starting to lose blood supply to her lower leg. She had developed what they call compartment syndrome. This is an extremely painful situation. Notice that each of these fascial layers, this is one fascial layer, this is a second fascial layer, and it's almost like the cranium where it protects these vessels and structures, but also with increased pressure, it will put significant pressure on these blood vessels and these nerves, and you'll end up losing blood supply to the lower legs and feet. Very, very painful. A fasciotomy is when the surgeon goes in and makes an extensive cut across the fascia. If it's like this snake bite, it's very extensive fasciotomy. In other places where access to medical care is more available, they'll make very small fascial incisions that are hardly noticeable on the skin surface. But in this situation, there are extensive cuts that extended, 8, 10, 12 inches down the leg, and the leg was completely open. The fascia was open for several days, covered up with gauze, of course, and cleaned up. But this was a very painful surgery. So this is her having her spinal block in the operating room, and then she is left awake during the procedure. And this is the size difference of her lower leg. The left leg is the one here. Swollen, painful, very painful. Notice that, again, no oxygen is needed, and since the patient is not getting a lot of IV sedation. One thing you have to know about spinals and epidurals from the get-go is that it blocks everything from the block down. So your sympathetic fibers are coming down your spinal cord as well. And if you block your sympathetic fibers, you will have vasodilation of all the blood vessels below the block. And so they can get a low blood pressure. So they still do need an IV, and they need IV fluids to help recover that hypovolemia. The other thing that spinals or epidurals give you the option of doing is being able to add a tiny, tiny dose of narcotic, which is morphine or fentanyl, Dilaudid. In Ghana, it was Demerol that we had available to us. And when you place that tiny dose of narcotic, you only need 1/10 of what you would use intravenously. And that little tiny bit is able to go into the spinal receptor sites and block them. This is an opiate receptor site in the spine. And you have natural endorphins. And that's why those opiate receptors are there, for your natural endorphins. And these narcotics attach to these receptor sites, and they will attach, depending on the medications, up to 24 hours in the case of morphine. So let's go on to some of the cautionary features about spinals and epidurals. Let's do a case presentation. This is a middle-aged man, and this is a true story from way, 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 way back in residency. A patient came to the emergency room with a stiff neck, confusion. The resident decided that he ought to have a spinal tap to rule out meningitis. In the case of a spinal tap, notice how the needle is going through these spaces, getting access and going below L3-4. Unfortunately, this man had bloody fluid. He also had high intracranial pressure, unbeknownst to the resident that was doing the spinal block. High CSF pressure. It was so high, in fact, that the blood and spinal fluid shot across the room. The patient had immediate herniation of his brainstem and he died. So the complications are for spinal needle, for spinal blocks, is that you can have brainstem herniation only if you have very high intracranial pressure. And the way you would make sure you don't have that is if the patient have a history of headaches or intracranial pressure. You can check that by looking at the retina to see if the optic disc was really, had a really clear edges, borders. You can also do an MRI or a CT scan. You also need to make sure on spinals that the patient doesn't have a problem with bleeding, because if they do have a bleeding problem, a coagulation disorder, low platelets, they can get a hematoma or bleeding around the spinal cord, which definitely you do not want. The other thing, of course, is infection or abscesses. That's extremely rare, but as long as it's a sterile technique, that risk is minuscule. And of course, the other thing that can happen is a spinal headache. And if it's with the thinnest, very thinnest needle, that risk of having a spinal headache is very low. However, I personally have had one myself, and we'll talk about that scenario in just a minute. So going back to the intracranial pressure, you can do an MRI or a CT scan. And when you look at someone's CT scan with elevated intracranial pressure from a mass, for instance, or a bleed, like a subdural hematoma or an epidural hematoma, this increased pressure pushes these ventricles, and you'll see what they call a midline shift. And this is an image here of the optic discs. This is just doing an ophthalmology exam to look at the back of the eye to make sure that this optic disc is not blurry. So this is the case presentation. A middle-aged woman having a spinal for lower abdominal surgery. The anesthesiologist punctures the dura twice, didn't feel like it was midline, so he tried it again. So 2 punctures through the dura, and 24 hours later, she starts complaining of a severe headache every time she stands or sits. So what's happening with the cerebrospinal fluid? It has several functions, but it has this nice way of bathing the entire central nervous, spinal cord and brain. So remember, it's the waterbed of the brain. So as this fluid might be leaking down here, it might be pulling on this area, these meninges. And so they might be, just by leakage might be causing pressure on the brain or pulling on them. The way you can tell a spinal headache is it goes completely away after lying completely flat. This is showing an example of spinal fluid coming out of a needle. This is where, and I call this the oh shit moment, because this is where you're attempting to place an epidural catheter for a woman in labor. The epidural needles are not intended to go as far as the spinal fluid space. And the needles are larger because they have to thread a catheter. So if that needle should pop through, then you're going to get spinal fluid, and the risk increases for a spinal block. The risk increases for a spinal headache. Oh, reminder, remember the meningeal layers that we talked about the 3 layers, the dura, the arachnoid, and the pia mater. If you pop into the spinal fluid space, to CSF, what are the 2 meningeal layers you just popped through? The pia and arachnoid, the arachnoid and the dura, or the dura and the pia? And the answer is you've just popped through the arachnoid and the dura mater. And as a review from former lectures, remember how the dura is the very most outer layer closest to the cranium, closest to the outside surface if you're doing a spinal block. And it's the thickest, heaviest. You feel the pop when you go through that. And then spinal fluid is between the arachnoid and the pia mater. So the spinal leak is felt that the spinal headache is felt to be due to that persistent leak. This is still controversial, all controversial how these spinal headaches work. Interesting is that over the age of 50, people are less and less likely to get a spinal headache, even with a bigger needle. So elderly people, you can actually get away with using a larger needle for doing spinal blocks. But these are some of the possible causes of getting these spinal headaches after a block. Now, this is a very self-limiting thing, but there's a couple things you can do. You can either wait it out for a couple weeks, lying down most of the time, drinking lots of fluid. Some people feel that if you ingest caffeine, that helps with the spinal headache. The other thing to do, and this treats it this treats the spinal headache immediately. You can take 10 or 20 cc's of the patient's own blood, and you can inject it into the epidural space, and the blood naturally clots and seals up that space. And all of this is done sterilely. This is almost immediate relief. So now let's go through what the differences are between the spinal blocks and the epidural blocks. This is showing an epidural needle going into the space. Epi means above, so you're going above the dura, not getting spinal fluid. And even though this is red, this is not blood, this is spinal fluid. This is the spinal cord. So below the arachnoid layer that's adherent to the dura is the spinal fluid space. The epidural is this space above the dural layer. And that's where the epidural is placed. Now, the epidural catheter, if it's done carefully, of course, can be placed very high. And this provides, pain control for even the most uncomfortable surgeries, particularly the very most uncomfortable surgery is thoracotomies. And those are placed, like if there's an incision across the chest, like a pneumonectomy, that will give pain control all the way up here. So the epidurals can be placed very high, a catheter threaded, and everything from there downward will have pain control. And that catheter is left for as long as they need it. If it's for labor, of course, then the epidural will be placed down here in the lumbar area. But if it's for thoracic surgery or for abdominal surgery, big abdominal surgeries do extremely well with continuous epidurals for several days after surgery. So in summary, the neural tube forms around the spinal cord very early in pregnancy. Folic acid is one way to ensure that the neural tube closes normally. And the other thing is the epidural can be placed all along the spine. If it's done carefully, it's placed above the dura. It's not going into the spinal fluid space. And that's a continuous catheter that's left behind. The spinal is one single shot, usually placed below the lumbar L1, L2. It's of a shorter duration, and it all depends on what medication is used. You could either use lidocaine, very short acting, or Marcaine, which can give you, 4 to 6 hours even as long. And then also both of these can allow for a small, tiny dose of narcotic placed to give an extra pain control up to 24 hours after the surgery. And that's really nice for patients that are having like total knee replacements, total hip replacements, other kinds of surgery. And any questions, please direct on the site. The PDF will be available through a link to Google and available for download and will be included in the comments section. Thank you.